I will mainly look at the low-cost ARVs, and I think it's partly been covered. Why did the cost of ARVs come down? The scale-up of treatment. I think one could talk about TRIPS and TRIPS flexibilities for at least a day, so to go through that in a few minutes will be a bit of a challenge. We'll also look at the role of India, as this group has done, and then look at the way forward for access to ARVs for least developed countries, but also for middle-income countries. I think this is a picture that at least those working in the field of HIV are quite familiar with. We've reached, I think, incredible progress over the last few years. When we look back in 2002, there were 300,000 people worldwide on ARVs. Now we've got 8 million people. I mean, that is incredible. But we still have a long way to go. It's 15 million who need treatment. Now, we've moved the goalposts a bit. We're starting at a CD4 count of 350. So, when people's immune system is still stronger. And I think we're expecting that the WHO will come out with new recommendation that might even put the goalposts a bit higher, but we'll see about that. But there's still a big challenge to put the other 7 million on ARVs. There's still, we've just reached a little bit more than half, and to keep people on treatment, and that's maybe even our biggest challenge, because it's treatment for life. So do we really have enough drugs to switch people when they need to be switched? This is a graph I've borrowed from the Medicines Patent Pool Foundation. I think it clearly shows that when prices came down, the scale-up happened. I think you were already talking about it this morning. Now, this is looking at the old first line. This is looking at nevirapine, stavudine, and lamivudine. Obviously, this is not the preferred first line anymore. But we see prices came down very quickly. The Brazilians came up with about a quarter of the price of the originator drugs. Then the Indian generic manufacturers came in and developed a triple combination, 3 drugs in one, which also helped with adherence, and we were down to $300 per person per year. In 2011, we were actually down to $60 per person per year for this combination, and it was not an Indian manufacturer that came up with it, it was a Zimbabwean. Varichem, I'm not quite sure. I don't know whether there are any Zimbabweans who know how to pronounce that generic firm. Varichem, thank you. Unfortunately, I think this generic company had problems because of not having the economies of scale to continue. Now, when we look at prices, the first line that's recommended now by the WHO, because stavudine has very serious side effects, is to replace it by tenofovir or AZT. It has brought up prices again. And it very much depends on what country you live in, whether you can use generic drugs, whether you have to use patented drugs. Efavirenz, the patent is running out this year. But in those countries where there is a patent, they are paying a lot more, 3 to 4 times more than those countries that are using the generic version. So here we see the first line, 170, maybe up to 200. The second line, which uses mainly protease inhibitors, where at 400 it can go up to 800. If we need third line, that's people who have been on treatment for a long time who really need to be switched to the very new drugs, we are in the thousands per year. Pretty unaffordable to most developing countries. I must say, I have not, and I travel a lot, I have not seen third-line drugs in Africa anywhere. It's very encouraging that South Africa will now introduce third-line, but we usually see only maybe 1 or 2 second-line, and it is the price that's prohibitive. In the Universal Access Report 2011, it gave the statistics that 97% of the drugs used in Africa and Asia are first-line drugs. Now, these countries have done antiretroviral therapy for more than 10 years. You would expect a lot more people to be on second-line treatment now. In Kailicha, where MSF started their treatment project, they found out that after 5 years they had to switch more than 12% of the people to second-line. So this cannot be right. There's something wrong, and it is probably the prohibitive prices that keeps people too long on the same ARVs. Now, this will be, as I say, a little bit of a challenge. The World Trade Organization was set up in 1995. I think many of us think it's always been there. It's not even 20 years old. But it has had a major impact. It came out of the Uruguay round. The Uruguay round mainly dealt with agricultural products, and I think we might remember some of the discussions of removing subsidies for agricultural products, liberalizing trade. In the Uruguay round, the country still had the option not to have patents on pharmaceuticals, and 50 countries decided not to. That option was not there later on when the WTO was set up, and TRIPS, the Agreement on Trade-Related Aspects of Intellectual Property Rights, were introduced, and some people have even called this an anomaly of the WTO. The WTO is all about free trade. It's all about liberalizing trade, and yet it's introducing something that protects the intellectual property rights and actually maybe makes trade a little bit more complicated. Basically, all countries had to introduce these international standards for protecting and enforcing intellectual property rights, including monitoring and dispute settlements. And maybe that's also a good thing, that there is a mechanism, a complaint mechanism. But so all WTO members, and there's 153 of them, so most countries are part of the WTO, are required to make patents available for any interventions, whether products or processes, in all fields of technology. And the big question is, what is a new invention? Yeah, and there's a bit of really leeway to interpret that. What is really new, and what is just maybe a slight modification. And this is where countries really have a bit of leeway to interpret that in their own national laws. And the patent term for protection is 20 years. Now, the middle-income countries only had to comply with TRIPS in 2005. And I will go a little bit into India, because that is one of the most important middle-income countries for us to have complied with TRIPS. The least developed countries have until 1st of January 2016, and I'll come back to that because there are certain efforts now to extend that period. What we've seen is that there was pressure soon after from Africa, mainly because of the HIV and AIDS epidemic, that people were a bit unsure, is this going against our right to health? How do we actually combine this? Are the trade rights now the overriding rights? And actually, the TRIPS already set out the flexibilities. The Doha Declaration just reaffirms that countries have the right to define when they can circumgo the patent rights for making sure that there's better access to medicines. And there's basically 3 major flexibilities. The most important are probably compulsory licenses. That is, that public authorities can authorize the government or a third party to produce generic drugs without the consent of the patent holder. They merely have to pay a royalty fee. Parallel importing means that a company sells at different price levels to different countries. For instance, when I buy my malaria prophylaxis in Germany and I go to a pharmacy, for the last 6 or 7 years I have not been able to get the German product of this company, but I usually get a re-import from Spain or the Netherlands. I can't say it's been much cheaper, but maybe the pharmacy benefits a little bit. Then there's the BOLA provision that basically lets generic firms use the data from the patent holder without, again, the consent of the patent holder before the patent has expired, in order to get marketing approval, because it still takes a while to reproduce the same drug generically. So when the patent has expired, the generic drug can then basically produce it. And then, of course, there's the important exemption for least developed countries, and we very much hope that this is going to be further extended. That means that a least developed country that has got manufacturing capacity can produce whatever they like. And they can also import, as long as they import from a country that doesn't have a patent on it. So it gives a lot of freedom to least developed countries. Why is India so important? India changed its Patent Act in 1970. And in 1970, it only recognized a process patent and not a product patent. And that meant that if you found another way of producing this, you were fine, because there was no product patent on the medicines. And that has basically led to the generic industry growing from about 2,000 companies in the late 60s to 16,000 in the 90s. And that has set, I think, the scene for the Indian generic firms to really boom and to also be on the scene when the production of ARVs came along. So we've seen a huge scale up in production of first-line ARVs. We also see that a lot of them are now producing second-line ARVs, and they've started from basically early on with fixed-dose combinations. And what we've seen, and we'll see on the next slide, is very important, is the export to Africa. It was through Indian generics that it was possible to treat people in Africa. So what we're seeing is, this is looking at the tenders between 2003 and 2008. It's, actually donor-funded purchases, over 17,000 were looked at, and we see about 90% of first-line and pediatric treatment came from India. But when we look at second-line, and this is the PI, the protease inhibitors, it's less than 20%. And again, it's the chicken and egg argument. You know, a little bit. It has to do, of course, with prices, and it has to do with patents. So when we look at what is pre-qualified now, and I've just printed out the list, and I've looked at, you know, what are the medicines. I only found Aspen Pharmacare and Varichem as the only African generics that are mentioned here, the only ones that are pre-qualified, despite the fact that there are many African companies producing ARVs. They are the only ones in there. And they are the old first line, basically, you know. So here I think we really need to see more improvement. What India did was it changed its patent law in a very good way, in that it excluded certain medicines from being patented. And so it did really do a lot against the evergreening. So if a pharma company just changes the medicine slightly chemically, it will not get a new patent if a new use was found. We know the first AIDS drug, AZT, was actually a cancer drug in the past, and in the 80s it was found that it actually works for HIV. Now that would be a ground to say, you know, sorry, but this is not a ground to give it a new patent. So, and this has been very good in really barring, you know, new, or some of the medicines from getting a patent, and therefore it has kept prices fairly low. So where do we stand now? And here I'm coming to the end. For the first line, we're basically fine. The first line is produced, it's produced in India to a large extent, it's also produced in Africa. The second line, we might be fine. It's, most of the Indian generic firms reckon that most of these drugs will not get patents, because a lot of them refer to substances that are known for a while. They are modifications, so again, they can be produced, but they are produced at much, much higher costs. But for the third line, when we really talk about new drugs, we have a problem. They will come under patent. Some of them are already under patent in India. So how can we have access? When people need to be put on third line, how will we have access to that? Now, what's the way forward? Here, least developed countries could play a huge role. They could play a huge role in manufacturing these new drugs that are under patent in other countries. But the period until 2016 is too short, because so far I think hardly any of them are producing second line. So to produce an even more complicated drug will be very difficult in such a short space of time. There is an intervention by Haiti. They are trying to, on behalf of the least developed country group, putting forward a request that the period should be extended indefinitely for least developed countries. As long as the country is a least developed country, it should not have to become TRIPS compatible. This will be put forward at the next TRIPS Council on, I think, the 7th of March. And we can only hope it's successful. I think many of the NGOs present here supported it with a letter. We hope that it has, you know, it will succeed. We need to prevent TRIPS plus provisions. We need to prevent that countries are forced to become TRIPS compatible when they really don't need to be. And we need to weigh up what makes more sense from a public health perspective. If it's much, much cheaper to introduce drugs from India, does it make sense to build up or to produce the same ones in their own country. It is really weighing up how many people can you treat at the end of the day. And it's using the opportunity to produce those drugs that we actually need, that are under patent elsewhere. But of course, for that, we need to build up manufacturing capacity. And what we've seen, that sad story with Verichem, that they stopped producing ARVs last year, is because the scale was not there. So again, you know, and this was a generic firm that had the pre-qualification, that we really, you know, that firms also need to produce for larger markets and need to be able to compete for global fund tenders. And here I come to the end. Thank you.